Okay, good morning. Welcome to our presentation on ED patient reports, intelligently streamlining and dashboarding to ensure patient safety and follow-up with myself, Una Rogers, Barry Gilahuli, Gabrielle Denaya, and Agnushka Bagarola, in collaboration with Dr. Adrian Muti. So the brief that we were giving was radiology investigations are commonly performed in the hospital, with over 60,000 coming from the A&E alone. And all of them require a follow-up to ensure that there are no findings missed. The current system, which was largely relying on a paper-based individual assessment follow-up, was very complex, had multiple points of communication, and involved reminder emails being sent from one admin area to multiple doctors. And despite this process, many tests were still having significant delay in follow-up and the opportunity for a missed case. Ultimately, the failure to follow up on any of these key investigations was associated with a significant risk to the patient, including death, and we knew that a robust and reproducible method was imperative. So as you can see from these photos, this is what's currently wrong with the patient, with the current flow. The scope for missing the reports, large volumes of papers being printed, a single point of failure, having one person review tests every day, workload pressure, inconsistent training and knowledge of what a normal and an abnormal report may be, and significant time spent with intern doctors, up to 2 hours per person per day, reviewing results, and administrative time, one whole-time equivalent secretary spending between 1.5 and 2 hours per day sending emails. Through our primary research, we did interviews with multiple stakeholders. This included 2 interns, 3 NCHDs in the ED, 1 SHO, 1 advanced nurse practitioner, 2 radiologists, 2 consultant EDs. We also discussed with the IT system and the NIMS coordinators in the matter. We did a lot of observation studies down in the emergency department and in the radiology department, and we had demonstrations of how the process was flowing currently and the use of patient-centered. We also calculated an estimate based on the amount of paper and time used on electricity on the computers, a CO2 carbon footprint of 3.6 tons of carbon per year. And just for reference, a high level in office would be 5 tons. We conducted interviews and got some really valuable insights. Consultant ED was saying that people are just getting frustrated because the number of emails was too high. The reports and the follow-ups were really depending on the intern's knowledge. We found out that the interns rotate every 4 months. Some of the junior doctors thought that most of the people don't know what the endorsement button even means. This is a button that is used to validate a report. Other doctors said that they don't mind getting the emails and that they did see the value in this system, but they felt that there was a better way of doing this. The commonality in this was frustration, and a sense that the system was a little bit of a surveillance, and that really ultimately they knew that the work needed to get done, but they wanted it to be more robust. So we mapped out the current flow as the problem was, and we used a Moscow to help us navigate to where the solution may lie. We knew that a solution needed to be user-friendly and standardized, easy for all of the MDT team to access it. We knew that there needed to be a focus on actioning rather than just endorsing reports. We wanted whatever that we came up with, if it was going to be an IT solution, to be viable and future-proof for future electronic health records. And we knew that we needed to address the constant trigger emails. We would have liked it to have some sort of dashboard and the capability to produce audits and reports. We knew that it should interact with the master IT infrastructure, and we knew that it should be able to communicate with the NIMS, which is the National Imaging Report functionality. And we knew that whatever we came up with should be able to make trigger emails possible. But we were very clear that whatever solution we had was not going to be in any way a diagnostic means of radiology reporting, and it was never going to replace the human in the workflow. These are our analysis process images. We knew that we needed to analyze the IT system, the paper system, and the admin secretary point of this was really important to us. From this, we had some potential solutions. We wanted to focus in on radiology and the potential of using AI. We knew that a digital list was important, and if it had an exporting functionality from the AI. We thought that education was really important, and perhaps having some sort of single point to access education so that new staff would be able to seamlessly access this. We knew that the solution needed to be some sort of a dashboard tracker that had multidisciplinary team involvement, and we knew that the dashboard was going to need to have a trigger email. So redesigned the workflow, inserting our possible solutions, and we brought this back to our champion, Dr. Muti, to reanalyze. And through this conversation, we then further redesigned the process. So this is our new asset. This is what we are proposing, a departmental workflow redesign. The faded out area is the old process. We are suggesting 2 new workflows with 3 new assets. The first workflow is in yellow. This is an AI workflow. This will start from the radiology point of view, and it will automate the categorization of reports into normal, inpatient reports, and abnormal. The normal and inpatient reports will then be discarded. Then the clinicians can focus on the abnormal reports. This is where we have suggested a SharePoint exporting system where AI will bring the abnormal reports to, and there will be a communal team. No longer will all of this work be solely dependent on junior intern doctors. We do appreciate, though, that the interns are very important, and we have suggested an educational QR code placed at the intern's work desk with a new system of operation procedure document that we have created so that they can easily and seamlessly work through Patient Center. The abnormal reports will then either have an action or no action. And if there is no action, then the system will trigger out reminder emails. This also means that the consultants can focus in on the locum doctors who will not always be present the next day on shift. This is a mock-up of what an AI dashboard would look like in the background of radiology. This is an example of an actual working SharePoint with patient information. Obviously, this is not real, but this is how it is. It's very seamless. It's a single pane of glass. This will be located in the A&E department and have password protection for only the doctors to be able to access. This is a mock-up of what our educational QR code would look like. This is an actual QR code, so feel free to scan this and have a look at our new document. This will be placed behind the desk where the interns commonly sit to review reports. And what we propose for potential outcomes, time saved, we estimated that 7 hours per day were used to screen these reports, and with our new system, it will be reduced to 1 hour per day. And our CO2 carbon footprint will be reduced from 3.64 tons of carbon per year down to 16.8 kilograms of carbon per year, which is a massive bio energy saving. Our final thoughts for success for this project: we acknowledge that artificial intelligence can assist with reading of the radiology reports. However, in healthcare, it does require extensive work to train the language model to ensure its safety. This is already starting in the radiology department, and we feel that there is potential to further expand this. The matter is awaiting the SharePoint deployment, and this software can provide an easier way to streamline and digitalize the current workflow. The QR educational SOP is ready and will make orientation of the new doctors and junior interns easier and more consistent. This will reduce the amount of reports being unnecessarily reported as abnormal. Dr. Muti is a passionate, patient-centered, holistic and empathetic clinician whose detailed care has led to this risk being highlighted and addressed, and our team hopes that this workflow can be implemented when the IT infrastructure allows it. Thank you very much.